Well, a warm welcome to this talk. Dr. Michael Cohen has kindly agreed to come and talk to us again, which is particularly pleasing after the grilling we gave him last time on vitamin D. So, Dr. Cohen, thank you for coming back. Thank you for giving us part of your Sunday.
I thought we were just having a drink down the pub.
Well, we are, but we'll see if anyone else chooses to listen, then they're more than welcome to tune in. Now, we've got quite a few things to talk about, but I know one of the things that you're interested in is patient education, and that's kind of where we want to go at today, doing things with the patient. So I've actually got a series of very hard questions here for you to answer. And the first one is, do you feel it's important in medicine for the individual patient to be empowered, or is it much better for professionals like yourself to retain control? What do you think?
I think the obvious answer to that is that, of course, I think that patients should be empowered, and I think they should be empowered with knowledge. I don't think that just handing over some nondescript form of power is a good idea, but I do think that having a conversation with a patient, I do think that building a relationship with a patient, especially in family medicine, I think that these things are crucial. I think certainly in my practice over the years, certainly from medical school and onwards, we were taught to engage patients, to try and get them to take responsibility for their health. I'm sure you know, probably most people know that medicine until not too long ago was quite paternalistic or maternalistic these days. I don't know. And I don't think that works anymore. Mm-hmm. I think there are certain situations when you need to have that kind of relationship whereby the doctor does need to say, yes, I understand this, and this, and I understand your concerns. But in this particular case, I really do feel strongly that you need to do this. And that's a part of the contract between a doctor and a patient. I think it's an interesting subject you brought up, because one of the things that troubles me is that nowadays medicine has become too much, perhaps trying to be politically correct instead of thinking what's actually for this patient. And so we don't necessarily want to be directive at certain points. And I think that we also don't give, well, let's just say I think that there's an opportunity to give the patient a lot more credit. I think that people, not everybody is a high-tea intellectual, but people do know quite a bit about themselves, and people are able to take responsibility, and people are able to be in a position where they're not helpless. They're not passive. I think passivity is very dangerous. I think that it's worthwhile trying to make another human being active and responsible for themselves. Otherwise, we end up creating a form of dependency. And I don't think that that's good.
Because when the patient leaves the doctor's surgery or the hospital ward, they no longer have that professional sort of sitting on their shoulder. That they have to sort of carry on with the rest of their lives. So they need the wherewithal and the information to do this in a way that makes healthy choices and generates a healthy lifestyle. Is that kind of what your thinking is?
Yeah, I think so. I'll give you a little something that just comes to mind right now. I remember probably about 15 years ago in the British Medical Journal, there was a study or an editorial done. I think it was a study, and it showed the perspective of the doctor and the perspective of the patient. So from the perspective of the doctor, they saw a patient with some abnormal result, and it became this very important fact that they needed to follow up that the doctor was crucially important for the long-term health of this patient, and that this issue needs to be solved. And so from the doctor's point of view, the patient, this specific patient, holds great importance, and the doctor is important for that patient. And then it showed the perspective of the patient, which was that the patient was with this doctor twice in the whole year. The calculation percentage of time out of the year that the patient spent with that doctor, and it was 0.00001% of the year. And the patient's view was very different. It's just like, okay, I saw that doctor, he told me that thing. They might remember it, they might not. And the doctor's thinking, I've got to follow up this thing, I've got to follow up this thing. And the patient's like, oh yeah, I completely forgot about it. Unless, of course, it's something really serious. So the perspective as to how important we as doctors are and how patients perceive that are two different things entirely.
But I suppose if it was something really important, really critical to health, for example, if the patient's potassium had gone up,
of course,
acutely, and they're about to have a cardiac arrest, you would communicate that with the patient so that they came to understand the importance of correcting that parameter as well.
But also that's the point when it becomes a change in the balance of the relationship, whereby you do become more paternalistic, maternalistic towards the patients. No, this is an emergency, this needs to be dealt with. You don't have time in that situation to have too much of a conversation to understand things. When it's something more chronic, and you need to enlist the patient as a partner in this, that's a very, very different thing.
So the doctors and nurses have a role as teachers.
As teachers, and also as someone who the patient is developing a relationship with. Because if certainly in family medicine, and I hope so also in other specialties, and I've seen it because I've worked in many specialties in the past, the ideal would be that a trust is built, a relationship based on trust is built. What I was trying to say earlier, I didn't say it very well, but what I was trying to say earlier is that there, during the time since I qualified, it became, instead of the doctor-patient relationship, it became healthcare providers and healthcare consumers. That's a very that's not an uncommon description of how people describe things these days, and to my great sadness, because there's a huge opportunity lost there when it's seen as some kind of transaction. There is an opportunity of so much more when you build a trusting relationship. There is so much more forgiveness and flexibility, and you know that that person is trying their best for you, and the patient is also trying the best, and you're not perfect and they're not perfect. To have this idea today where, heaven forbid, anything should go wrong, because life is perfect, right?
Absolutely.
That's just not somehow able to be tolerated, and I think that's a problem, and it results in less good medical care.
I mean, I was in hospital for a relatively minor procedure recently, and I was very happy to be the patient. I didn't want to be a consumer of healthcare. And I was really happy when the staff nurse came around and sorted me out and told me what to do. And, there was agreement there. But, I felt like I was being managed by someone who works in this specialism all the time. And, they were communicating with me. And I just felt comfortable being the patient.
So that's more of a blessing of the NHS, which I feel very lucky and privileged to have gone through all my training in the NHS and years after working in specializing, etc. In other countries, you'll find that when the system is not socialized, it becomes one much more of a transaction. Even if the patient isn't directly paying at the point of contact with the doctor, it becomes you're the doc. You're here to provide a service for me.
Mm-hmm.
I'm the consumer. I'm the customer.
Yeah.
And that's very problematic in medicine, where you really do want to build trust, and you want that trust partly so that the patient can say to you, I feel like something's going wrong with my care, or whatever it is, and that you have that ability to communicate without feeling like this is not okay.
I'm going to be a bit naughty now and ask you a question that's not on the list, Michael, but it's just sort of come to mind. Do you think this enhances the placebo effect that the patient enjoys?
What specifically? I don't.
Well, the fact if you believe in the healthcare provider, is that going to give a boost? So if I give a drug and say to my patient, well, this is a really good painkiller, this has been prescribed by a really good doctor, and I think it's exactly what you need at this moment, then that's going to have the analgesic effect from the pharmacodynamic effect. But because the patient believes it's going to work, it's going to have an additional 30, 40, who knows, 30 or 40%.
Absolutely. I mean, it's quoted as 30% probably on average, and only for a certain period of time. I think the placebo effect is something remarkable, and I think we are using it all the time when we build that trust.
Exactly.
And I think it's even been shown, I know it's been shown if I go into the realms of psychology, there are various forms of treatment in psychology, whether it be psychodynamics, whether it be cognitive behavioral, there are various forms, Gestalt, I can't think of many names at the moment. There's lots of different forms of Kleinian.
Yeah.
And what's been shown time and time again is that the quality of the relationship that you have with the therapist is most likely the determining factor in what will bring you to a better state of health in your mind.
Yeah,
not just the therapy itself.
Absolutely, yeah. It's all part of that therapeutic process. I think that's a powerful point. Now, the next question is on the script, so that's not quite so bad. Is it important that patients understand their health and how to promote health?
I mean, the obvious answer is yes. But I always try to think of the less obvious.
I mean, should we be in a situation where the patient lives as they like, does what they want, and if I get sick, don't worry about it, Dr. Cohen will give me a pill to make it go away? No,
but I think it's very dependent on each human being and what their particular attitude is to health. And we can't assume that everybody is the same and that everyone has the same priorities and that they are going to listen to what I say, and they may not be ready to hear what I have to say. I might have to say it 50 times over the next 20 years before something clicks. Or maybe it never will, or maybe I'll say just the right thing tomorrow. And and I've had situations like this. All doctors can tell you these stories where surprisingly they had a 2-minute conversation with a patient about stopping smoking and losing weight. Patient didn't come back for 6 months. They come back 6 months later for a cold, and you notice that they're 14 kilos lighter, and they stopped smoking. They stopped smoking a week after you told them to. And you ask them what happened, thinking that they've gone to some life-changing workshop, retreat, and no, it was that 2-minute conversation. But usually that 2-minute conversation is built on a significant period of time and trust that they've gotten to know you. And you said it at the right moment that they needed to hear it as well. So it's a confluence of factors at that time. But those things happen, and they're remarkable when they happen, actually.
Yeah, and it's pretty good feeling. You know that the penny's dropped, and the penny's
dropped, but also the patient, to come back to your earlier question or point, the patient has realized at that point that they are not passive.
Yes.
That they have become active in their own health.
Yes.
So when you ask, should a person know everything about things? I don't know, meaning in certain situations, yes, and it depends on the personality of the person. And in certain cases, no. Some people are just, they're okay to trust you and they get it. They don't need to do the research. When I go and see a lawyer and I ask them for their opinion about something that I need to know, for example, or an accountant, I'm not going to start drilling them down and finding out exactly why, where in the law does it say that? It's like,
yeah.
I've gone there because I trust the guy.
Yeah.
But with health, I think there are certain advantages to knowing certain things. So it may be helpful for someone to understand a little bit about their physiology, to understand why it's good to do sport, to do sport regularly. It might be useful for them to understand a little bit about sleep, to understand why sleep is so important. I mean, it sounds obvious, right? Do sport, sleep well. These are what we would think are innate, and they're a part of our day-to-day lives. And we can feel the effects pretty quickly. Sleep well or we don't sleep well. But if someone has a problem with losing weight and you tell them, well, actually it's because you're not sleeping well, or that one glass of wine that you drank each night is actually disturbing the quality of your sleep, and it's causing an inability for you to lose weight because it blocks the weight loss mechanisms, let's say, without going into too much detail. That could be really helpful to somebody.
So they do know what you are saying is based on science,
right? But also something that they can form a mental picture of what that is.
Yes, that's meaningful without being patronizing. It's meaningful for them. Because I think what patients often don't realize that even at the highest level in medicine, there's many things that aren't known, many things that aren't evidence-based. And I mean, personally, I've been studying biology and physiology all my life, but I still feel that a lot of what I understand is just simplified models of explanation. It kind of seems to make sense, but whether that's the absolute ultimate reason that something's happening, I very much doubt I know that in any area. Right? So we all use simplified models.
So we suffer from the same problem.
It sounds like it. yeah.
I used to enjoy, in medical school, I used to love understanding mechanisms.
Yeah.
And I found facts. Of course, many facts are important, but there are things that take second place in our memory over time. And they become less important because when we really need to know some specific facts, we just look them up.
That's what Google's for, isn't it?
Yes. But to actually have a whole understanding of the system, how it all interplays, and to interpret the clinical signs is a totally different thing. That's why Google is no good for those things. That's why when patients come in here looking apologetic and saying, I Googled it. That's why I'm in this mess, or why am I here? Because I read about something that I really don't understand, and it scared the wits out of me. Then this is where medicine comes into play. The experience of actually seeing people day after day, night after night, for years and years, and actually having an understanding of how the illness interplays with each person in a different way.
Yeah. I know personally, if I'm ill or in pain, I'm very happy for someone to come and sort of take control and to tell me to stop being stupid. And it's just there's something about the other person coming alongside and taking an interest, and yes, taking a degree of control that personally I find relieves my anxiety rather than. So if I'm ill, the last thing I want the doctor is coming explaining it to me. I just don't want to know, really, because in fact I sometimes wish I could forget everything I do know when I am ill, because it just seems to upset me a bit more.
Well, everybody is different, and I think I think the idea is to know what the line is for each person, and to know when to relate certain information to them and when not. And it was an interesting word that you used, the word interest. You said something else, then you said interest, then you went on to saying something else. And I think the interest of the doctor and the patient is important.
Yeah.
It's not enough to just to explain or whatever, but to actually take an interest, to actually understand who is this person in front of me right now, and also where are they, because it's the same person that I saw 3 months ago, but they're in a very different state of mind at the moment, or they're in a different place in their life.
Yeah.
And to be able to put that in the context of their current symptoms or their concerns or an illness that they don't know that they have or don't know the extent of. This is a very different thing.
It's very much a live time thing, isn't it? It's you've got to react to the circumstance in front of you at that moment.
Right. In the textbooks, it says these are the symptoms of so-and-so disease. You go through the list of symptoms. You then know the signs that you're looking for when you examine them. You know the tests that you're supposed to do. But then there's the whole person.
Yeah.
And their life, and how one thing transposes onto the other.
Yeah.
And their relationships and all of these other factors that come into play.
It gets quite complicated, really, doesn't it?
It's interesting.
It is, yeah.
It's never-endingly interesting.
Indeed, yeah, that's right. People often say, "Don't you get bored?" But I mean, I just when I retired and just worked as a junior staff nurse on the A&E department, and people said, "Don't you get bored doing that?" Well, the answer is no, never, because every patient is different.
Yeah.
So you might just be doing a 12-lead ECG and doing the blood pressure 10 times a day, but it never gets boring because every patient's different. It's well, you might be giving the same drug every time, but every patient's different, so it just keeps it interesting.
Yeah, and in addition to them being different, they each have a story. They each have a joke. They each have something that you can relate to on a human level, and these are also indirectly, inadvertently therapeutic events.
No, I take that entirely. Yeah, the fact that you've had the fact that you're saying something that the patient relates to on a human level is that I agree, that's a therapeutic component. So the next point I've got down here is medical dependency. Do you feel that some patients are more, or have you had patients that become sort of over dependent on you rather than being independent?
Yes, but I'm quite allergic to dependency.
Right.
So I feel it very quickly. I'm sure many people do.
Yeah.
Definitely in my case, I'm quite allergic to this, and I can pick it up on an instinct, and I'm very quick to try to help the person to become active. Again, I'm going to go back to this. There's very much when you mentioned the subject of the talk, I didn't do much about in terms of reading about it or thinking about it. It was more that I saw it very much in terms of being passive or being active. And I think that you can translate this into many parts of life. Whether a person takes on something in a passive way or whether they are active. If I want somebody to, I'm going to digress for a moment, but
please do.
I remember learning in medical school with cancer treatments how if you are, they said that there's 3 types of reactions and 2 of them do well. They said there's the person who fights and says, I'm going to survive this, they do well. The person who is apathetic does terribly. And the person who's in complete denial does great. So
interesting.
It's the 2 extremes that work, but the apathy is not good.
Yeah.
Apathy also engenders helplessness. It's like, well, am I here or am I there?
I'm just being bobbed around as like a cork on a sea. Well, there's nothing I can do about it.
Right, but when someone is in an active mode and fighting mode, okay, that's very clearly active. When someone's in denial, it may be also a form of activity. It's something we genuinely think of. We think, oh, someone's in denial, they're like they've moved off to the side and they're just not. But they actually be, I mean, it's a survival mechanism, right? We don't acknowledge all pain all the time at the moment when it's happening, because if we did, we'd be bombarded by so much. And for some people, I guess denial is a way of getting through things, but that's not necessarily having a passive patient.
Interesting. So you have a high index of suspicion for medical dependency, and you're able to preempt it, I think, is largely what you've.
I do things to disencourage it. I do. Things I try to poke or stimulate people to think.
Yeah.
I think that thinking is so important. I mean, it sounds like the most obvious thing to say. It's like, you don't need me on a YouTube video to say that. But thinking, learning to think better, is not simple, and we're all terrible at it. And we all need to learn and reassess ourselves the whole time. The moment we make assumptions that we have got something, we probably haven't. And things change, and our emotions interplay with our thinking. And there's a big difference between worrying about something, for example, and thinking about something.
Yes.
Worrying goes around in circles, and thinking may seem to go around in circles, but it's progressing forwards. So trying to get people to think, trying to I don't want to use the word force, but to push people,
facilitate,
but to aggravate, to agitate somebody a little bit, to make them think about what they're saying, about what their words actually mean as to what's going on inside them. I think it's a very important part of medicine. Self-realization. Yeah, but again, coming back to it, making somebody active, making them an active partner in treatment.
How do you see the difference between compliance and concordance?
Same thing. Okay. Compliance is passive, concordance is active.
Yeah, so concordance is you coming to an agreement rather than saying, do this.
Yeah.
Yeah, got it. No, that's a very good way to summarize it. Yeah, I like it. Yeah. Yeah. Do people need a level of knowledge and understanding in order to make informed decisions about their health? Silly questions, these, aren't they?
Yeah, they're not so silly. You know that they're not.
I mean, what level of knowledge do people need? So, I mean, if you think about diet, how much sort of information would you try to give, or would you give them a handout and say, well, go away and memorize this? Or
well, I'm not particularly good with handouts. It's something I definitely need to improve on that. I'm pretty terrible with handouts. I do tell people to read various things, and I sometimes direct them to, when I think I found a good website on something useful, then I might direct them to that. I try to keep things as simple as possible, but everyone's different, right? You've got some people who really want to know all the details, in which case I'll try and give them a brief summary of the physiology as I understand it, and hopefully as we in general understand it. And then you have someone else who just understands, all right, don't do this, do that. Tell me what to do, doc. What should I do? Should I do this or should I do that? Should I eat this or should I eat that? And then I give them, it's at a different level, but it's all they want to know. Yeah. It's all they want to know.
And some people will accept that. Yeah.
And some people will accept that. And I also don't think, clearly our bodies are able to handle all sorts of different diets. It's only about what the consequences are, and that's complicated. Nobody knows. I can't say to one person if they eat hamburger and chips every day for the rest of their life, smoke 20 a day, that something bad will happen to them. Because there are going to be a few outliers who've got these incredible genes where they can live till 100 perfectly happily. I can tell them that on average, the chances are not good, and you're probably going to feel very good, and your brain's probably not going to function as well as you'd like it to, etc., etc. And again, I also don't want to, I want to bring people to reality. I don't want to give them this illusion that, yeah, sure, do this, and yeah, you'll probably be okay. I tell them, look, this is the reasonable course of things that's going to happen. And by the way, we've just done some blood tests, and look, here are the signs of it already.
Yeah.
There are various parameters that you can use to understand the person and to work out with them what is good for them, and then to start working on it. And it's a process. It's not certainly in family medicine. It's a process. You're not going guns blazing the first time you meet someone, unless it's something really obvious and dangerous. You are hoping that over time, with slow but thoughtful education, that a person will realize themselves what is the best way for them to live and how to do it.
So I've got a question.
Sorry, many people know what, but they don't know how, or they don't have the wherewithal to do it, or they don't have the energy to do it. And then those things need addressing as well. But I think health is generally pretty simple. It doesn't need to be very high tech. Most health is based on a few, for our chronic long-term health, I'm calling it chronic health as opposed to chronic illness. For our long-term chronic health, it's pretty simple. We know what to do. Most people know what to do.
I've got a question written down here. I don't really understand it, so maybe you could explain the question before you answer it. Is there a risk for medicine to medicalise? What do we mean by sort of medicalising things?
I think it's already sadly happened to a large degree. Yes, it's more than a risk. I think it's already very present. Medicalising is the process by which we take the normal range of the human experience and turn aspects of it into a medical problem with a label and a treatment plan, if you like. One example I can think of this is probably back in the 1940s, 1950s. There were around, I don't remember the exact figure, but around perhaps 100 different psychiatric diagnoses, and that might be a stretch. Today, there are close to 400. And what's actually happened is that people with shyness have been defined as having a particular syndrome. People with some variation of that have been defined as having social anxiety. People who were just a little bit odd before are now being called on the spectrum. And yes, there may be an ounce of truth to this, but is anybody normal? Meaning nobody's perfectly normal. And if I want to, I'm sure I can come up with a list of diagnoses for myself.
Oh yeah, I could bore you with a long list of mine, that's for sure.
Right, but the point isn't that. The point is, are we functional? And how well do we function? And also, do we appreciate the richness of each other in this world? Because honestly, if I saw a whole world of normal people around me, I might go nuts. The world is interesting because people have their quirks, their foibles, their differences, their reactions, to try to make everything this uniform
stereotype.
It doesn't sound very attractive to me. And I'm not saying that we should encourage suffering or anything. When people really have a serious problem, we take it seriously.
Yeah, of course, yeah.
I think what medicalisation is when we, for no great reason, find a way of labeling something.
Yeah.
And then saying, you fit the definition for this, therefore you need this.
A medical treatment.
Right, even though the person in a different society would be seen as perfectly normal. If I was up with a bit of an extreme example, if you were to take somebody in the West who had a mental illness, which could be fairly severe, but it could be that they're just a bit odd, and they function in life, whatever. But in another culture, they may be seen as a holy man because they come across in a certain way.
Yeah,
and that's great. Right? But because we make that abnormal in our culture, that person is already being stigmatized, labeled, instead of just finding a way to accept people with their differences. And these are probably not the best examples of day-to-day things that are being medicalized.
No, it's a good one.
I think that we do have a tendency in medicine over the last, certainly since I've become a doctor, to overly medicalize things and to put a lot of energy into that, instead of saying, hold on, yes, we know that these things happen, but instead of putting all our energy into medicines only, we should be shaping policy, and government policy could be encouraged to be, okay, how do we subsidize food so that there's more healthy food in the supermarkets? How do we and encourage people to eat that food? How do we subsidize sports and get people off their bottoms and onto the sports playing field? How do we make people resilient? Right, we're living in a very sanitized world. How do we make people resilient? Because it's not always going to be sanitized, and in reality, many times it isn't.
That's right. Yeah. And the other thing that comes to mind there, everyone's normal till you get to know them. Normally, the first time you go for lunch with someone, you realise they're not normal.
What are you trying to say?
Nothing. No, I mean, at work, many times, you go to a professional meeting with someone, and they'll seem logical, rational, what you might call a perfectly normal person. And then you go to lunch, and the conversation is less formal, and you think, oh, that's a bit odd, or that's a bit strange, and the charade is never maintained for long.
Who are you going to lunch with?
Oh, academics. Various people that work in hospitals. Can some diseases be prevented? If so, how? So maybe an example there. What sort of common disease do you see that could be prevented with education, with lifestyle, with a holistic approach?
Diabetes. It's a straightforward one, and a very common one, unfortunately.
Yeah.
It never used to be anywhere near so common just 20 years ago, and it's being described as a worldwide epidemic. And yes, there's broadly there are two types of diabetes. There's type 1, which is usually starts at a young age and it's autoimmune in nature, and there's type 2, which is a result of diet and not moving for most people. So gaining weight, insulin resistance, and type 2 is being treated for many years now with various medications which do keep it under some kind of control. They control the glucose, but they don't control the disease, because the glucose isn't the disease itself. The glucose is the result of the disease, and it causes the complications of the disease.
Yeah.
The actual disease is truer to say is insulin resistance. So the body's cells are no longer reactive to insulin. They're not sensitive to insulin. And this is crucially important that they should be. And the ways to make them sensitive to insulin, number 1 is to lose weight. Number 2 is to do exercise. And all of these things come together. And this is, number one, it's avoidable, it's preventable in the first place. So if we were to have healthier food, if we were to eat healthy food, do exercise, sleep better, and minimize portions, you'd avoid diabetes. We have so much sugar in the food today. Sugar is one of the main problems. It's not just sugar, but it's processed, ultra processed food. I should say. It's processed food. Lots of foods are processed. If I have bread, if I go to a good bakery, they make bread. That's actually a processed food. Yeah. Anything that's been milled and then it's gone through a process of fermentation. It's also a process. If I want to be silly, so if I'm not eating just raw food. But ultra processed is something beyond that. Ultra processed means the addition of various chemicals. It means turning something which is one food into something completely different. And our bodies are not evolving or haven't yet evolved quick enough to handle those changes. And so, yeah, there's a classic example of something that can be done to prevent diabetes, and diabetes is reversible. It's reversible with all of those measures, cutting out ultra-processed foods.
So some diseases can actually be reversed. The disease can actually go backwards, and someone can get long-term better.
There's evidence today that many diseases, the chronic diseases, many of them can be reversed.
So if a patient comes in with a fatty liver, for example, you could hopefully get them to have a non-fatty liver within a period of 6 months or a year.
It depends on the degree of how fatty their liver is. It's, if it's a very severe fatty liver, it could take years, but a mild one could reverse within 6 months. Even that's a bit optimistic. Most of the time it takes at least a year. And someone who's got a more severe fatty liver, it can take significantly longer, but it's an effort. We shouldn't take our health for granted.
Yeah.
It's a real effort to maintain your weight, your not just your weight, but your health. And it takes doing regular sport, it takes sleeping well, minimizing alcohol consumption, all the unpopular stuff, unfortunately. I'm not here to make people very smiley today.
Oh no, well, a lot of people are smiling at this, I'm sure. Now the last question I've actually got.
Thinking this guy's got to be joking.
No. This is people will be smiling at the something or other. I'm sure they'll be smiling. Well, I'm smiling, so that's good. Right. Last question I've actually got here, although I've thought of another one too. We'll see how we go. We all seem fairly well fed in Western countries. Even a lot of people, as we've said, are obese. So presumably nutritional deficiencies aren't a problem.
I wish that were the case. And this is a big subject, but first of all, when I was a kid, I remember seeing famines on TV on a regular basis.
So do I, yeah.
Fortunately, there are some people in the world today who are in a state of famine induced by war, as we all know. But most of the world today is not at risk of dying of malnutrition in terms of not eating insufficient food. Most of the world is at much higher risk of dying of overfeeding. Having said that, there's a difference between weight gain and nutrition. And so you can have even a lean person who's malnourished. They may be lacking very vital elements, very important vitamins or important minerals. You have to ask me the question again. I'm sorry, I've forgotten.
No, we're saying that people seem well fed in Western countries, so a lot of obesity, so presumably they're not nutritional deficiency. But come to think of it, we did a video on vitamin D, didn't we?
Yes.
So that's a common deficiency, that people actually don't have enough vitamin D very often if they're not in the sunshine.
Yeah, I mean, I think that there are different aspects to that and different arguments and probably different genetics. So not for one person, even though they seem like they have a relatively low level, it's adequate for their genetics, but somebody else has a high level and it's not adequate for their genetics. And the problem we have is not being able to identify what applies to whom. But in the cases of other things, for example, iron, which we're not going to go into now, I think, because it's a big subject.
I've got those questions here for when you're energized.
Iron deficiency is very common. It's very common especially in the developing world. It's also quite common in the developed world for various reasons, including veganism, including women being far more likely to be iron deficient than men because of the menstrual period. It's common even in people who you wouldn't expect. So people who are just very sporty. People who do a lot of sports, they have much higher iron needs. Their body needs much more iron. And so, yeah, I mean, you can be malnourished, not just in iron, it may be in B vitamins, it could be in magnesium. There are various reasons for that. It can be also because of medications. Certain medications cause the loss of certain minerals from the body.
Yeah, it's the whole field of nutrition, isn't it? And we will be doing another video on iron and iron deficiency, which we have been promised for some time. So, Michael, I've distracted you for nearly 3/4 of an hour now, but I have got one last question. And again, this isn't on the list, so quite unfair of me. But do you think doctors are sometimes tempted to treat the symptoms of a disease rather than the cause? Because if you treat the symptom, the patient will kind of feel better straight away. Is there a tension there between symptomatic treatment and causal treatments, do you think?
I think that we need to be doing both. We can't just treat one and not the other. And yes, it may be easier to treat the symptoms, but they're going to come back and bite you.
Yeah.
They're going to, they'll bite the patient first and they'll bite you next. We shouldn't just be treating symptoms. That's the long and short of it. Sometimes in the acute setting, you have to just treat the symptom and then figure out the underlying cause afterwards. In the chronic setting, you definitely need to be simultaneously looking for and treating the underlying problem. And if you don't, then you're not really treating the problem.
No, that makes sense. We need to, and the other thing that hasn't come across in words really on this talk, but I think it's been all the way through, is the idea the whole idea of patient holism. It's the whole patient needs to be treated in the whole social, religious, cultural context of that, family context of that individual.
I think at the least they need to be understood in that context. You can't enter into every aspect of a person's life. You can only allude to certain aspects, and you can make the patient aware of those aspects. But yes, that's a very important part of being able to enlist the person as a partner in their own treatment.
Well, Dr. Michael Cohen, that is a fascinating insight into, I don't know, would we call that philosophy of medicine, or would we call that common sense of medicine? Something in between those two, perhaps.
I heard someone say recently that common sense is not so common.
Yeah, I think that may well be true, but let's hope this has increased the commonness of common sense. So thank you very much for that, and we'll look forward to anyone who wants to comment, and let's I suspect we'll get a few, but thank you. I found that fascinating insight, and I'm sure a lot of healthcare professionals and non-healthcare professionals around the world will find that really quite fascinating. So thank you for your time on a Sunday afternoon.
Thank you for yours.
Thank you.
Bye-bye.
Bye.